Ashwini.
Hi everybody, I'm Ashwin.
I'm Raj.
And I'm Eddie.
This is Blood Cancer Talks. This is a podcast exclusively dedicated to hematologic malignancies where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today, we are excited to talk about the management of paroxysmal nocturnal hemoglobinuria, also called PNH. We have an expert, Dr. Robert Brodsky, who is the director of the Division of Hematology and professor of medicine at Johns Hopkins. He's also 2023 American Society of Hematology president. Dr. Brodsky, thank you so much for joining us and thank you for your time. Before we start, can you tell us about yourself and your clinical and research focus for our listeners?
Sure. So it's a pleasure to be here. So I have been interested in bone marrow failure states for a long time, and my clinical interests relate to bone marrow failure states and also complement mediated disorders such as PNH and other complementopathies that we often refer to them. I run a research lab that also studies complement, and the other major interest of mine over the years has been the use of cyclophosphamide to originally get rid of autoimmunity and ultimately alloimmunity, and opening the door for haploidentical bone marrow transplants for bone marrow failure states and sickle cell disease.
So, Dr. Brodsky, in your clinic, you only exclusively see bone marrow failure disorders?
No, my clinic is pretty broad. I mean, it's I've had to narrow it a little bit this year just because of the time constraints from ASH, but I even see some hematologic malignancies, less and less these days, just because I don't have time. But most of it is complement-mediated disorders, so that can include PNH, that can include atypical HUS, that can include antiphospholipid antibody syndromes, HELP syndrome. I also see a lot of aplastic anemia, congenital bone marrow failures, etc.
We're looking forward to talk a lot about complement for the best part of the hour, but we did want to ask you what your motivation for wanting to become ASH president and what your sort of vision for the year looks like.
Yeah, so I never had it. I never envisioned being ASH president. But it kind of evolved. I mean, I got involved in ASH a little, probably over 10 years ago, as the chair of the bone marrow failure study section. Well, even before that, I got an ASH Scholar Award from ASH when I was a junior faculty, and that played a big role. That really helped me jumpstart my career. So I realized that ASH was doing wonderful things, and I figured if I was going to get into administration type stuff, I would rather do that and keep it to hematology than to be, a cancer center director or a head of medicine. I just had never had an interest to do that. I wanted to keep everything related to hematology and my research rather than I saw that ASH was a very global organization, and that's really, I just came back from Vietnam for the highlights of ASH. It was just eye-opening to see how interested people from all over the world who can't get to the ASH meeting were, and how knowledgeable these people were. I met with some of the fellows there. They were just amazing, and they were so appreciative of ASH coming to the parts of the world that they really can't get the education. So it's just a wonderful organization. It just does a lot of good things. I mean, getting these ASH-focused fellowships where people can train in benign and malignant hematology and not do solid tumor, I think is really important. I mean, why should you train in a field where 70% of what you see is not what you're going to be doing? And I would say on the flip side, with people who want to do oncology, solid tumor oncology, why should they have to manage sickle cell and TMAs and PNH and aplastic anemia if they want to do lung cancer? I mean, it just makes no sense. So I think getting we're not separating the fields, we're separating the training so that people can train in what they want to do.
All right. Thank you so much, Dr. Brodsky. So let us jump right in. We will start with a case, and you can walk us through how you would approach this patient, and we can discuss the data and questions as we go. I think first let's start with this case I saw in the clinic. This is a 66-year-old female with no significant past medical history who presented with symptoms of sore throat, fatigue, easy bruising, and dyspnea on exertion. Her blood count showed a white count of 1.8, hemoglobin of 6.1, and a platelets of 50. She underwent a bone marrow aspiration and biopsy to further evaluate this pancytopenia, which showed markedly hypocellular marrow with a cellularity of 5 to 10% with rare hematopoietic elements. No abnormal blasts or lymphocytes are detected by flow. Just a mild erythroid atypia. Cytogenetics were normal. Myeloid NGS panel showed a ASXL1 mutation with a variant allele frequency of 5%. We also sent for flow for PNH, which showed a significant population of monocytes with GPI anchor loss, which is 52%, and granulocytes with 60%. And gating on erythrocytes by CD45, CD59, and glycophorin A detected 80% type 1, 3% type 2, and 17% type 3. So with this, she was diagnosed with aplastic anemia and PNH overlap. So for our audience, can you first give us a 10,000 foot view of what is PNH and why the name PNH? And other thing I sometimes struggle is how do you explain this to a patient?
Great. Okay. Can I ask one more question? Did you have a retic count and an LDH?
LDH was done. It was in 650.
And the reticulocyte count?
I do not have retic count right now in front of me.
Yeah. Okay. Yeah. So this is the most confusing area that I get the most calls on. I'm glad you presented this case. It's the aplastic anemia PNH overlap. I think everyone knows how to treat aplastic anemia, although that's changed right now. And I think you're going to see immunosuppression go away. I think most people know how to use complement inhibitors for classical hematology, and that makes sense. But this group here, and what I ask myself is what is causing the patient a problem? And yes, you presented a case where there's this big PNH clone, but that's not the problem here. And that's why I asked for the retic count. I bet the retic count's low. The problem here is bone marrow failure. So you need to address your problem at the bone marrow failure. That PNH clone is only slightly more relevant than that 5% ASXL1 NGS. I mean, you're not focusing your therapy on that, and you didn't even pick up the PIG-A mutation on your NGS panel. Isn't that scary? So this is a case where I would focus my therapy on aplastic anemia, but I would also recognize that if I just improve hematopoiesis with immunosuppressive therapy, that PNH clone is probably going to come out later. Not guaranteed, but probably going to come out later. So that's what I'm thinking. Now you asked what's PNH. PNH is a clonal hematopoietic stem cell disorder. It's caused by a mutation in an X-linked gene called PIG-A, and the product of that gene is responsible for it's one of 7 proteins responsible for the first step in the biosynthesis of GPI anchor proteins. GPI anchor proteins. GPI is a moiety that anchors a whole class of proteins to the cell surface. And two of the most important ones from the standpoint of the disease are CD55, which controls the C3 and C5 convertases, and CD59, which controls terminal complement. And it's the reason these patients have a hemolytic anemia when they have a large clone. Our cells are constantly being tested through the alternative pathway with C3b. And if we don't have a way of clearing it, the cells will lyse. And it only takes one membrane attack complex to land on a red cell to lyse it. So if you're missing CD55 and 59, especially 59, your red cells are going to lyse, and that's why you get this hemoglobinuria. The other important feature about PNH, it is one of the strongest prothrombotic disorders around. And I think a lot of people have forgotten now that the leading cause of death from this disease was thrombosis. And that happened in about 40% of patients. And once patients started to clot, you really couldn't stop it. Sure, you would put them on anticoagulation, but you would treat the acute clot, but they would continue to have clotting, and that's what would kill them in spite of anticoagulation. Once the complement inhibitors came into play, you no longer had the risk. As a matter of fact, I consider it a provoked event now, and I don't keep people on long-term anticoagulation with complement inhibitors. I just anticoagulate them for 3-4 months and then stop it as long as they're well controlled on a complement inhibitor. But this is an overlap. And here, your problem is aplastic anemia. This is aplastic anemia, capital AA, with PNH, small PNH.
Thanks, Dr. Brodsky. I think one question that patients sometimes ask is whether PNH is considered a cancer. How do you express that, given that this is a clonal process? So sometimes I struggle to explain whether this is a malignancy or not.
So I would say no, it's clonal. So to me, cancer is unregulated clonal growth. Probably the simplest definition of cancer is unregulated clonal growth. This is clonal growth. It's regulated. So, but, kind of like LGL, do you consider that a cancer? That's clonal growth. That's a clonal autoimmune disease. Someone who has a CALR mutation, who it's clonal disorder. Eventually it might, turn into a cancer. But this is, it's more like a mole is clonal, right? CHIP is clonal, MGUS, clonal. So where you draw the line of what's cancer and what's clonal, I would probably say this is not a cancer in what we traditionally think of.
Okay. The patients ask this question: is it inherited or is it acquired, or is it always acquired?
The PNH is always acquired. It's the interesting thing is there's over 30 genes involved in GPI anchor biosynthesis. So back many years before you guys were in medicine, we used to think it probably wasn't going to be just one gene that causes PNH, and with rare exception, it is one gene. And the reason for that is PIG-A is on the X chromosome. And because this is an acquired disorder, it just takes a single mutation to knock out PIG-A function in males and in females, because females, through lionization, there's only really one active X chromosome. So it affects males and females equally, and it just takes a single hit. All the other genes involved in GPI anchor biosynthesis are on autosome. So it would take, an inherited plus and that's happened in a gene called PIG-T. but that's super, super rare. There's probably not 10 cases in the world. Now, just a quick tangent there. We have described germline PIG-A mutations. That doesn't cause PNH. That causes a disorder of intellectual disability and seizures. And these are all hypomorphs. These are patients that have a leaky stop codon usually. So they express some GP protein deficiency. Because if you have a germline PIG-A mutation that knocks out all function, it's embryonic lethal. You can't get past the early stages of development. But if you have a small amount of GP proteins, you can, and you develop a very severe neurologic disease that is most children die within a couple years to a decade.
One other paradox of PNH is the PNH stem cell produces this red blood cell which does not have CD55 and CD59 anchor proteins. But why does the clone grow in size despite it being producing red blood cells which are hemolyzed all the time?
Yeah, great question. As a matter of fact, that's what got me into the lab. When I was a fellow, and this is just good general advice for trainees. I like to teach residents and fellows to what I call read backwards. And what I mean by that is, especially today, medical education is just absorbing information and recognizing patterns. And you really don't get a chance to think. And so when you read a paper or when you go to a lecture, rather than just taking at face value what is in up to date or what is in a lecture or a paper, try to read the paper for where the holes are in the field. What doesn't make sense? What don't you understand? Because that's where the research questions are. And that came up over and over again. How do you have a clone that is more vulnerable to complement-mediated destruction achieve clonal dominance? Doesn't make sense. That's what I wanted to study. And so there's a couple ways that can happen. So you all know about clonal hematopoiesis right now. It's the big new thing, huh? We've known about clonal hematopoiesis for decades. PNH was clonal hematopoiesis, right?
Right.
Just imagine you have clonal hematopoiesis. Let's say you have someone with a CALR mutation. Let's say you have someone with, you can have clonal hematopoiesis without even having a mutation. That can occur, or one that you know about. Now you get a PIG-A mutation in it, right? So here's your 30-40% clone, and now you get a PIG-A mutation in it. Bingo, you got classical PNH, right? JAK2, CALR, whatever. There's your classical PNH. Or, like your patient here, you can develop PNH out of aplastic anemia. But the fascinating thing is it only comes out of immune-mediated aplastic anemia. Fanconi anemia, dyskeratosis congenita, those patients, they don't throw out. Yeah, there's rare cases. I've described one, but that's just true unrelated. But the association between acquired aplastic anemia and PNH is real. As a matter of fact, if you look at adults, 60 to 75% of adults at presentation, just like your patient, will have a small to moderate size PNH clone. And that is immune selection. So GPI anchor proteins are involved through NK and T cell mechanisms, and I won't go into it right now. It's NKG2D is the predominant pathway. It makes PNH stem cells less susceptible to the immunologic attack that you have in aplastic anemia. So it's a conditional growth advantage. And it's hematology is all about Darwinianism. The cells who are under immune attack are trying to escape that immune attack. The second most common genetic abnormality to come out of aplastic anemia is loss of 6P. That's where HLA is. Yeah. About 20-25% of patients with acquired aplastic anemia will have 6P LOH. You won't pick that up on your gene panels. So PNH is a way of escaping that autoimmune attack, and it gives it a conditional advantage that doesn't exist under normal hematopoietic conditions. So those are two ways that you can get expansion of the PNH clone: escape or already pre-existing clonal dominance with another mutation or another process epigenetic involved causing clonal hematopoiesis.
Yeah, thank you, Dr. Brodsky. One other question is, that is something I see a lot of trainees struggle with, is how to identify as well as diagnose PNH. I know you did an excellent tutorial, I think a few months ago, about the flow for PNH, what it means, and how to look for it. Can you please walk us through how to identify PNH and diagnose it?
Sure. So, I mean, it's really a simple diagnosis right now, and it's just a flow assay, and different labs use different reagents. And most use FLAIR in conjunction with monoclonal antibodies that recognize other GP anchor proteins. Nice thing about FLAIR is it's a protein that recognizes the anchor itself. So,
what is FLAIR?
So, FLAIR is derived from Aeromonas hydrophila. It's a protoxin that causes damage by binding to GPI anchor proteins and oligomerizing and poking a hole in cells, just like complement. And many years ago, we discovered that PNH cells are resistant to this protoxin because its receptor, the GPI anchor protein, isn't there. So what my colleague Tom Buckley and I did is we mutated the protoxin such that it could still bind to the GPI anchor protein, but it wouldn't form channels. And then we put on a fluorescent tag, Alexa Fluor, so that it would fluoresce. So it's a protein that binds GPI anchor proteins that fluoresces, and it's a very useful flow cytometric reagent that looks for the absence of GPI anchor proteins on the cell surface. All blood cells have GPI anchor proteins on their surface. Different blood cells may have different ones, but they all have GPI anchor proteins. And this, makes it very simple, a simple reagent on granulocytes and monocytes and stem cells. The only cell that it won't work on really well are red cells, because the glycocalyx interferes with its binding, so you don't get good separation. So we still use CD59 on red cells.
Do you also send PGA mutation testing along with the flow to diagnose? Okay.
I don't want to get off too many tangents, but I always say it's better to have a functional test than the genetic test, unless the genetic test is pathognomonic for it. If you're looking for BCR-ABL or a JAK2 mutation where it's the same spot every time virtually, okay, a genetic test is fine. But a lot of times, especially when you're and I'm teasing you guys on these gene panels, but I tease our fellows and junior faculty as well on that, because a lot of times you're acting on something and you don't even know if it's functional. Just because there's a variant there, you don't know that it's really or a germline variant. I mean, how many times have you sent off a gene panel on a patient with a TMA looking for atypical HUS, and you get something back and you read it and it's gobbledygook? Probably damaging mutation. Clinic. How do you know? So having a functional test is very important. When you look for short telomeres, what would you rather have, a gene test or short telomeres by flow fish? When you send Fanconi anemia, you have all these different pathways, but if you have chromosomal breakage, it's more important. And it's the same thing in PNH. If you're missing GP proteins, you don't need to send anything else. That's really how you make the diagnosis. The hard part of the diagnosis relates to your case and deciding on what you need to treat. Do you need to treat someone because they're either clotting or hemolyzing from missing GP proteins, or do you need to treat someone because they have severe cytopenias due to bone marrow failure? That's the important. That's where the difficulty lies.
I wanted to ask, Ashwin asked, how do you diagnose PNH? I wanted to sort of take one step up and say, what, other than obviously aplastic anemia, which we'll talk more about, what makes you suspicious? What when you hear a case presented to you makes your kind of radar go off for, oh, this might be a case of PNH?
Yeah, great question. So basically what you're looking for is from the standpoint of hemolysis, you're looking for a Coombs negative hemolytic anemia. Okay. So patients with a Coombs negative hemolytic anemia, that's I'm thinking PNH. So it can be obviously other things that do that, but that raises my suspicion. The LDH in that is usually it's intravascular hemolysis, so it's usually really high for patients that have classical PNH, often in the high hundreds or thousands. So those are the ones, obviously if, about 25-30% of patients will give the classic hemoglobinuria. Some of them will have symptoms of smooth muscle dystonias. What that is when you have massive intravascular hemolysis, you release free hemoglobin. Free hemoglobin scavenges nitric oxide. So PNH patients will often give a history of difficulty swallowing, sometimes even liquids. They'll say that the food gets stuck. They can't get it down. Males will give a history of intermittent erectile dysfunction when that occurs, and a lot of times the patients will complain of abdominal and back pain. And especially if you see these, if a patient gives a history of these paroxysms that occur after a viral infection, things like that's been going on for some time. So that's from the hemolysis standpoint. Then there's the patients that can be very difficult to, in the sense that people often don't think about it, and that's the clotting phenotype. So some patients will present with more of a clotting phenotype, and they don't. The incredible thing is a lot of them don't have dramatic hemolysis. So they'll present with unusual clots. They'll present with Budd-Chiari syndrome. They'll present with portal vein thrombosis. They'll present sometimes with dermal vein thrombosis. They'll present almost with a skin rash that if you don't biopsy it and find. They'll present with central retinal occlusion. Just any kind of strange clotting also raises the specter, especially if in the setting of that clotting you see some cytopenias, you see some maybe a mildly elevated LDH. Those are the ones that you really need to be on the lookout for.
I think one thing you mentioned is about hemolysis. Is it always intravascular hemolysis, or there is some evidence of extravascular hemolysis as well?
Yeah, so it's yes, it's always intravascular prior to therapy. When you throw therapy in, then you can see the extravascular. But if you're not opposing C3b from landing on a red cell, the conversion from that to the membrane attack complex occurs so fast that you don't even see the extravascular hemolysis. It's pretty much all intravascular.
I want to dive a bit more into this sort of overlap of aplastic anemia and PNH. And I wanted to start by asking you, what's the chicken and what's the egg?
Yeah, it's a good. So I think the initial event is aplastic anemia. It doesn't have to be, though. We talked about someone getting clonal hematopoiesis and then getting a PIGA mutation in that clone. So if you've already got hematopoiesis where you have a clone expanded to 50, 60, 70%, and then you get a PIGA mutation in that clone, you can get PNH really fast. So the aplastic anemia overlap, the 21-year-old, who probably doesn't have clonal hematopoiesis at the time, who develops immune-mediated aplastic anemia and has a 2-3% PNH clone, that PNH clone is probably an escape mechanism to the autoimmune attack. So in that sense, the aplastic anemia is coming first, and then years later, the PNH can evolve, especially if you use immunosuppressive therapy. If you use transplant, you avoid that.
And what proportion of PNH patients also have aplastic anemia?
So it's a tough question in this, but it's a good one. So most patients with PNH have some underlying bone marrow failure. Now, it may not be to the extent that it's clinically relevant. So these patients, they may walk around with a white count of 3,100, an ANC of 1,800. It's maybe a little low, but it's not causing a problem. Maybe their platelet count's 127,000 instead of 240. So a classical PNH patient, they have a small amount of bone marrow failure underneath it, usually, not always. Some of them will have almost stone cold normal counts other than the anemia. Some of them actually with the clonal hematopoiesis underneath will have an elevated platelet count, I've even seen sometimes. But usually it's normal to low.
And do you check for a PNH clone in every patient with a new diagnosis of aplastic anemia? And if
Absolutely.
so, how does it influence your management of the aplastic anemia if you find a PNH clone?
Yeah, that's a really important point. So I absolutely test everyone with aplastic anemia for a PNH clone. And it's very helpful in the diagnosis. Let's take your 66-year-old and with cytopenias, and you do a bone marrow. It can be sometimes very hard to know what's going on. Is this? More likely it's going to be an MDS than an aplastic anemia, just for incidence of disease. And the 21-year-old I talked about. You want to rule out inherited bone marrow failure disorders. That's what you're thinking about more so than MDS. So the reason you send the PNH clone is not so much to make a diagnosis of PNH. It's really to help you understand what the diagnosis, what the bone marrow failure state is. So in your patient, who 66-year-old, you wouldn't expect them to have more than maybe a 30% bone marrow cellularity. So 5%, yeah, that's pretty low. But say it was 20%, but seeing that size of a PNH clone really makes you think that that's immune mediated because of what we talked about, the PNH clones escaping the autoimmunity. And in your 21-year-old who has a small PNH clone, right off the bat, that this is not going to be Fanconi anemia. This is not going to be, sure, you might send those just to be, doubly sure. But if you have a small PNH clone, you can be pretty darn sure this isn't short telomeres. This isn't Schwachman diamond. This isn't Fanconi anemia. And that's important because if you're taking that person to transplant, it could influence your conditioning regimen, A. And if you were going to give immunosuppressive therapy, you would feel better about it that you weren't treating an inherited bone marrow failure disorder.
Absolutely. Some recent studies have shown that a PNH clone might predict a good outcome and survival with immunosuppression. Do you factor that at all into your decision making when you're treating aplastic anemia?
No, there's probably a slightly higher chance of response, but it doesn't tell you that the response is going to be durable. And the problem with immunosuppressive therapy and aplastic anemia is even with the addition of L-trombopeg right now, you have a less than 50% 2-year failure-free survival, which means at 2 years, your patient either still needs immunosuppression, they've relapsed, or they've gotten some god-awful clonal disease, monosomy 7, coming out. It doesn't really change things a whole lot for me. It helps me more in the younger patient, and in a patient like you just described. I wouldn't give this 66-year-old Vidasa, for example. Bone marrow transplant, and it's now even with half-match donors, has cure rates upwards of 90 to 95%. It is less expensive than immunosuppressive therapy right now, believe it or not. A half-match bone marrow transplant can be done for less than $200,000. When you add L-Trombopag to ATG cyclosporin, and you're keeping it on for 6 months or more, you're up to $500,000 in 1 year. And 50% of those patients are ultimately going to go to bone marrow transplant anyhow. So we've really moved away from immunosuppressive therapy, except in the very rare instances where you absolutely can't find a donor. That's unbelievably rare now with haploid transplants. And the other group that I would use immunosuppressive therapy, what I ask myself is this patient likely to live 10 years if they didn't have aplastic anemia? And if the answer is yes, and they have reasonable organ preservation, I would take that patient straight to bone marrow transplant. And I'll bet you're all three of you are surprised that 66-year-old, if you didn't tell me that there was some god awful malignancy or some horrible cardiomyopathy or she was on dialysis, I'd take her straight to bone marrow transplant, even from a half-match donor.
With no immunosuppression.
No immunosuppression.
Yeah.
That paradigm is going to shift. Keep your eye out on blood.
Sure.
It's going to be coming out very soon.
Sure.
Sounds
good.
good.
To that.
Sure. So next we wanted to touch on thrombosis. So as you know, one of the biggest challenges of managing PNH is the prothrombotic tendency, which is a frequent cause of morbidity and mortality. As you alluded to, prior to the era of complement inhibitors, was one of the major causes of death. So what is the mechanism behind this prothrombotic tendency in PNH?
They're asking great questions. That's the focus of our lab now. Complement and the coagulation cascade evolved at the same time. And there's a lot of crosstalk between the two. As a matter of fact, a lot of the enzymes in coagulation and a lot of the enzymes in complement are serine proteases. And there's a lot of crosstalk between them. I earlier talked about complementopathies. One of the cardinal features of complementopathies is thrombosis. I mean, you think of cold agglutinin disease, these patients, clot like crazy. You talk about PNH, leading cause of death, thrombosis. Talk about antiphospholipid antibody syndrome, CAPS. They clot. Atypical HUS is microvascular thrombosis. I mean, so that is a cardinal feature of these disorders. So how is it that complement is causing the thrombosis? And a lot of people are studying that, including our group, and I don't think anyone sufficiently answered it yet. But I can tell you that we hardly see clotting anymore in PNH, and we don't even keep them on, even the ones that present with the clotting phenotype, we don't even keep them on anticoagulation anymore after we've treated their clot and treated their PNH with a complement inhibitor. We will remove the anticoagulation after 3 to 6 months if they're well controlled.
I think one probably follow-up question I wanted to ask about thrombosis. Is there anything particular in the flow you're looking to see that these are the patients who are at highest risk of thrombosis? No?
Yeah. So sure. One of the things, there's a lot of people put an emphasis on clone size for treating PNH, and I don't, with the exception of the clotting. So just because someone has a large clone size doesn't mean you need to jump in and treat them right away, because there are some patients that have a relatively large clone size they're relatively asymptomatic. They may have a little hemolysis, but it's not dramatic. They're not having any clots. You don't need to jump in and treat them right away just because they have a relatively large clone size. And the same thing with the aplastic anemia PNH patient. This is a common mistake. People will look at that 50-60% PNH clone and say, this is PNH, not aplastic anemia. And they'll treat the PNH, and you'll get that 600 LDH down, but you're not going to stop the transfusions, and you're not going to stop the neutropenia. But clotting is important. So before the institution of complement inhibitors, there was no question that the patients with PNH clones over 50% had a greater risk of thrombosis than patients that 5, 10, 20, even 30% PNH clone. Once a complement inhibitor's on, that just goes out. It doesn't even matter because they're all equalized. The other thing that you should do in the workup, in addition to the LDH and the retic count is I always send a D-dimer very early on in diagnosis, and if that D-dimer's up, they're probably having some thrombosis. A misconception about PNH is that they're always going to develop these large vessel clots, like in Budd-Chiari. It's got to be a hepatic vein thrombus. It's a big clot right in the hepatic. It's usually microvascular, actually. Just like you see in atypical HUS and HELP syndrome and CAPS, or veno-occlusive disease, gives you a Budd-Chiari syndrome, but it's usually not a big, clot there. So it can be small vessel thrombosis. So a D-dimer is something I also send and pay a lot of attention to.
Okay. So is it fair to say that there is no role of prophylactic anticoagulation for patients with PNH?
A blanket statement like no role, probably not, but very little to no role. The anticoagulation doesn't really work. So you're treating yourself if you're treating a patient, with and saying, I'm going to put them on prophylactic anticoagulation. It doesn't work. Yeah, and you also got to remember that a lot of these patients have thrombocytopenia. So putting them on anticoagulation is not always that safe.
I think this is a nice segue to the next part of our discussion, which is the anti-complement therapy. So let's say, for example, this is a patient, we have the patient with classical PNH, not the aplastic anemia and PNH overlap, which I presented earlier. How do you make a decision about treatment of a classical PNH patient who is having hemolysis with severe anemia and symptoms secondary to that? And I know right now we have 3 FDA approved medications for that. And how do you decide which medication and how these medications differ?
Yeah, so let's talk about how do I decide therapy. So you got to ask yourself, is the patient symptomatic? First of all, and that's not as easy a question as I just recently had a young guy in his 20s, pretty well preserved counts. His hemoglobin was running in the high 10s, low 11s, good platelet count, good neutrophil count. LDH was in 600 to 700 range. I really had to pull out of him that he was having, some symptoms of dyspnea and exertion. But then you got to ask yourself, well, are those symptoms worth getting an IV infusion and having to come in, and get, so you don't have to rush in a patient like that. If they tell you, hey, I'm going to the gym, I'm going to work, I feel fine, I'm my life is great. You don't need to jump in there unless there, someone, starts having clotting or something like that. Or if I saw a D dimer and an LDH that's progressively climbing and a D dimer that's progressively climbing, I would tell the patient, I think we should start I realize you're not having tons of symptoms right now, but that worries me. And so I've done that sometimes. And usually when you do that, the patient says, "Oh, I feel so much better. I didn't realize I was having," because it can be, but that's a rare patient. Most of them are quite symptomatic. Most of them will tell you that they have extreme fatigue. They aren't able to do what they used to do. They can't work out anymore. They get home from work and they're completely washed out, and they have to go to sleep. I mean, that makes it easy if they're having a lot of symptoms that way. But realize that you're treating the intravascular hemolysis. That's what you need to treat. So if they are anemic and their hemoglobin's 8.9 and the retic count's 2, you're not going to have a big impact from a complement inhibitor. That's bone marrow failure under there, or some other cause of anemia. Maybe they're iron deficient. Maybe maybe they have B12 deficiency. Maybe they have some other process going on. So that's what you need to think about. As far as which ones, my go-to drug as of today is ravulizumab. That's a C5 inhibitor, blocks terminal complement. It is, the nice thing about that medication is after the first 2 doses, it's given every 2 months. So a patient only has to get 6 infusions a year. And that is really a quite an effective drug that's tough to beat. There is another drug that's approved called Pegcetacoplan that is a C3 inhibitor. It's a pegylated peptide. The problem with that drug is it's very cumbersome to administer to patients. It has to be given by a subcutaneous infusion. So the patient has to be hooked to a pump and put 2 needles in the abdomen or in the leg, and it's given over 30 minutes through infusion. The drug has to be refrigerated. So, travel is, not the greatest with that. And a lot of the patients, not a lot, but several of the patients will need it more than twice a week. Some need it every other day. Some need it almost daily. So I reserve that for patients that are having, and I'm coming back to the extravascular hemolysis that you brought up. The extravascular hemolysis, and your probably next question is explain that. So the way it's easier to do this with a figure, but if you think of CD59 being at the bottom of your computer screen and the C5 inhibitor being in the middle of your computer screen and CD55 being at the top of your computer screen, that visual might help. So what C5 inhibitors do is compensate for the CD59 deficiency, but because CD55, the other complement regulator, is upstream of C5, you can, the cells get decorated with fragments from C3, and they get opsonized by the liver and spleen. Then you can get this extravascular hemolysis. Almost everyone on a C5 inhibitor will have some extravascular hemolysis. And that's why when you put them on these drugs, they still have an elevated retic count, they still remain anemic, but most of the patients will become transfusion independent. And usually that anemia is relatively mild, where they're either asymptomatic or mildly symptomatic. What you do stop with C5 inhibitors is the clotting, and that's the leading cause of death from this disease. So when you put someone on a C5 inhibitor, if they're running, let's say your 66-year-old had classical PNH, she's retired, she maybe plays golf once a week and goes out with her friends and goes out to lunch and is involved in some charities, whatever, volunteering, says, I can do all those things. I feel great now. Leave her alone. Even if her hemoglobin is 10.9, she's not having trouble with the dailies of active life. On the other hand, if she was 8.3 and is spending a lot of time in bed and fatigued and unable to do the things that she was doing before, and has a high retic count, but a normal or barely elevated LDH, and is having lots of extravascular hemolysis, that's the type of patient I may offer something like Pegcetacoplan that can actually address both the CD55 and the CD59. I would have that discussion with her about, is she willing to do these infusions, things like that. The good news is, maybe not for that company, but I think that drug's going to go away in the sense that it's just too cumbersome for patients to use on a regular basis. And there's oral complement inhibitors that are coming out that are also upstream that are probably going to take that option away.
Yeah. One other thing is when you're explaining these complement inhibitors to the patient, what are some of the potential side effects, as well as, I think the biggest thing we are worried about, the infection risk.
Yeah. So this is targeted therapy, not not what we do in some of our malignancies. To call that targeted, using the term loosely. So when a real targeted therapy addresses the pathway that's causing the disease and has predictable side effects. You don't develop GI failure, pulmonary failure, heart failure, your ear falls off or something. I mean, when you block complement, especially terminal complement, there's really only one side effect. And that is an increased risk to Neisseria infections. And that's why these patients need to be vaccinated, and younger patients I keep on penicillin prophylaxis because they're the ones that are most susceptible to it. So that's the major side effect that you have from these. There's really not much else in the way of infectious risk. There's possibly some with maybe some fungal infection. I just haven't seen that. But the main risk is Neisseria.
One other question is, which something I've seen some of the physicians describe about as, especially for a patient with aplastic anemia and PNH clone, if you're treating their aplastic anemia with immunosuppression therapy and they're getting their horse ATG, it can trigger massive hemolysis from the PNH clone. Is it something you discuss with the patient, or how do you mitigate this?
Yeah, so I mean, your patient had a hemoglobin of 6.1, and so you're probably transfusing your patient. And when you transfuse that patient, the size of the PNH clone is going to be so small that they're not really going to get significant hemolysis from that. So it's usually not an issue. There are some patients that have clotting prior to their immunosuppressive therapy or their bone marrow transplant that I do overlap the drugs. But if they're having clotting and they have bad bone marrow failure, they really need more definitive therapy than immunosuppressive therapy. It's usually not an issue but there are some patients that have had severe aplastic anemia with clones like you presented in your case that are actually having some small vessel thrombosis causing pain or other manifestations. And I will put them on eculizumab. That's the shorter acting C5 inhibitor because I'm not going to be, there's no advantage of doing the long acting one. And I'll just give it until they get started with their conditioning regimen. And once they're the conditioning regimen started, you can pull it off.
Well, we can't help but ask you then, who gets an allogeneic transplant? Which of your patients? How do you decide when and which patients to refer for transplant?
Yeah, so I just got a call from your neighbor in New Zealand about a young patient with PNH and thrombosis, and very life-threatening thrombosis. And as you're aware, there's no complement inhibitors available in New Zealand right now, other than on clinical trials. So that's a patient that should go to bone marrow transplant. But in countries where complement inhibitors are available, they're so effective that we don't do bone marrow transplant in these patients anymore, even though transplant-related mortality is now down for bone marrow failure states down to, I quote, patients less than 2 to 3%. That's higher than effectively zero, if you're talking about a classical PNH patient. Now, the patient you presented, I view as aplastic anemia. That patient needs a transplant. Now, again, I wouldn't quibble at this point if someone wanted to say, hey, we're going to go with immunosuppressive therapy, and if we get a good response, fine. But I think we're really moving away from the era of immunosuppressive therapy. At 10 years, the failure-free survival is down to 25 to 30%. So, and that's why I asked myself that 10-year question. So if you have a 45-year-old or a 50-year-old, I mean, are you really going to be happy, telling them in 10 years there's a 25% chance that, there's only a 25% chance you're going to be off therapy and have relatively normal counts? Or do you want to take a therapy right now that has a better than 95% chance of getting rid of that? And, a lot of these patients are going to need a transplant anyhow. So transplant's very rare for a classical PNH.
One other thing is there any risk of transformation of PNH to MDS AML?
There is. Any clonal disorder it's small, and there are, again, it's mainly probably coming from the bone marrow failure. So patients who have immune-mediated aplastic anemia and don't have a PNH clone have a 15 to 20% chance of developing MDS in 10 years. And the most common is monosomy 7. So if you have a patient with aplastic anemia and a PNH clone, yeah, they have a chance of going on to developing MDS. And again, that's why we are moving transplant up front. That MDS can be inside or outside of the PNH clone. So again, I think it's more from the underlying bone marrow failure. There is a risk from the underlying disease, but it's pretty small, especially in a classical PNH patient.
Finally, I think you briefly mentioned about factor B inhibitors as well as factor D inhibitors. Do you think that these inhibitors will replace the C5 and C3 inhibitors completely in the future?
Yeah, I'm glad you asked that question. No, and I'll tell you why. I'm scared of these drugs. I'm excited for these drugs, but I'm scared of these drugs. And I'll explain what I mean. And we're involved in clinical trials, and we actually helped do the preclinical development for the factor D inhibitor. They're very effective. I'm worried that they're going to be used inappropriately. And, you've all seen, the patient with a DVT or a PE who's either non-compliant or, is a huge fall risk. And it's frustrating when you have someone put them on, again, treating themselves, not the patient, because they just want to put them on a DOAC and get them out of the hospital. But not everyone's a good candidate for a DOAC. Especially if they're non-compliant, because then they come back in with a clot. No, they're a DOAC. Well, they are a DOAC failure, not from the drug failure, but because you put a patient that's non-compliant on it. So what worries me about these very short half-life drugs is what happens when you take someone who has a clotting phenotype, for example, and you put them on a factor B or a factor D inhibitor that has to be taken twice a day, and now they get a stomach flu. They just went on a cruise to the Caribbean. They came back. They got a bad norovirus or rotavirus. They're throwing up. They can't keep anything down. Complement amplifies, and they miss their drugs. They're going to have massive hemolysis and probably clot. And so when the nice thing about ravulizumab, and it's not a perfect drug in the sense that they still have some extravascular hemolysis, but most patients don't have much of that extravascular hemolysis and have good quality of life. Their clotting risk goes down to almost an age-matched control. You're going to have to select these patients very carefully. The other important point here is C3 and factor B are acute phase reactants. So the level of the drug that is controlling complement and preventing hemolysis and potentially thrombosis at steady state may not be the same as when you have the flu, or you develop mono, or have a bad cellulitis, or need a surgery. So yes, I think these drugs will start to become used up front. I think I will start to use these drugs up front when they become available, and I think both of them will be available within the next year. Danicopan will likely be approved as an add-on to C5 inhibition. Iptacopan, the factor B inhibitor, will likely be approved as a standalone drug. I think the patients that are the best candidates for this will be patients with classical PNH whose manifestations are primarily hemolysis. I think patients who are on C5 inhibitors who are having a lot of extravascular hemolysis could be switched to these drugs, and I think you'll see a lot of that. I'd like to see a little more data on clotting before I switch the clotting phenotype on there. I suspect it'll be fine, but when they're blocked, they'll be okay. But when they're breaking through is what scares me. So I still think we're going to have to learn a lot about these and how to use them and using them in the right patients. But yes, I think they will encroach upon ravulizumab. Pegcetacoplan, unless that drug can be formulated in a different way, I'm worried about.
Thanks a lot, Dr. Brodsky, for your time. This was excellent discussion, and I'm sure our listeners will really appreciate of all the interesting clinical tidbits you alluded in this episode, and we look forward to having you again on our podcast in the future.
That'd be great. You guys ask all the right questions, and